We talk a little bit about what the issues are. So one of the things that's happened in COPD is that we really pretty much last year branded COPD orange. Valerie's got her orange scarf on. And so what we really hope for is that the same way that, that you think about pink and the month of October as what? Breast cancer. We want you to start thinking about and have the entire country thinking about November is orange and therefore it's COPD awareness, right? And so we're moving in that direction. We know that you get an annual proclamation from the state of California designating November as COPD Awareness Month, but there are a lot of activities around that where individuals can engage with Breathe LA and other coalitions where you can really engage in the process of promoting the fact that November is COPD Awareness Month. We also have drafted COPD legislation. One of the things that the U.S. COPD Coalition has done is they got together and we took a look at gaps. So we have really designed gap legislation. We want to address all the federal agencies that have oversight in the area of health and ask them to focus on COPD. We have a piece of legislation that will not be introduced in this session of Congress, but hopefully in the next session of Congress. And one of the things that it asks for is that we have a coordinating committee that takes a look at what's happening across the areas, all of the federal areas with oversight of health. And that would include the Centers for Disease Control and Prevention, the National Institutes of Health, the Food and Drug Administration, the Agency for Healthcare Research and Quality, HRSA, the Office of Minority Health, because as you heard, this is a disease now that is striking minority populations and women. I think we have the Office of Women's Health up here, the EPA, Indian Health Services, Veterans, and CMS and DHHS all together. Let me just stop at this slide because I think that what's here in the middle is really, this is critical. This is really a critical moment in COPD because we are really moving away from this concept of shame and blame. You smoked, you did this to yourself, too bad. That's not what they tell people who have diabetes or heart disease if they're overweight or obese. This is really the moment in time where we need to really focus with the BRFSS on data collection. Prevention, we're very concerned about tobacco and prevention, but also awareness. Where are the other 12 million people who have not been diagnosed? Educating these individuals in their own self-management, treatment, and additional research. And in fact, I want to tell you that the largest lung disease research grant that's ever been given out was given out a couple of years ago to take a look at the relationship between COPD and genetics. So Alpha-1 is a model, and what we'll find is that people are genetically predisposed to developing COPD. COPD is personal for me. My mother has very severe bronchiectasis. Never smoked, not one cigarette, didn't even try it behind the schoolyard, and yet suffers from very, very severe COPD, frequent exacerbations, and very poor health as a result. Now, she probably has a genetic form of COPD, we just haven't determined which gene it is. It's going to be not alpha-1, but beta-1 or something, something else. One of the things that the legislation does is it addresses almost all of the health-related agencies. It creates a coordinating council at the Department of Health and Human Services. It asks the CDC to focus on an action plan. We've actually shifted that strategy to the National Institutes of Health now. It addresses prevention, diagnosis, and treatment. And it has a general theme of more research, better coordination, increased surveillance, more public awareness, and education programs. I will also note that I think it's very impressive that Breathe LA, I see the materials over here from the Learn More, Breathe Better campaign, which is the National Institutes of Health campaign. It's terrific that Breathe LA has been accepted and recognized and credentialed as a partner with the NIH, and that they have gone out and expanded their community network. And this is one of the areas that you're lucky enough to have some focus. So there are a number of pieces of legislation that are pending now on the federal level. There is a bill that increases access to respiratory therapists. This bill is currently HR 941. It's been introduced by Mike Ross. He is a blue dog, a Democrat from Arkansas, who probably is going to run for governor and probably will not be back in the House of Representatives again. In fact, he has announced his retirement. What this bill does is it recognizes respiratory therapists under Medicare Part B so that individuals can see a respiratory therapist in an outpatient setting. They do not have to be hospitalized to see an RT. There is a Veterans Initiative, which was introduced by Congressman Cliff Stearns. He's a Republican from Florida. This is HR 168. And what he did is he took that comprehensive piece of COPD legislation that I was talking about, the draft that we had, and he broke off a piece of it. And in fact, we drafted the legislation that way. So we have a big fat bill, and it's got dotted lines. So you can break off pieces of it if you want to. And he broke off the section that has to do with veterans and has introduced this piece of legislation that asks veterans to focus a little bit more, that asks the Veterans Administration to focus a little bit more on the diagnosis, treatment, and management of COPD. We have a COPD Congressional Caucus. So what's a caucus? I mean, there are hundreds of congressional caucuses. You hear about them all the time. There's a congressional boot caucus where they wear cowboy boots. What a caucus is it's really a group of individuals within Congress who have been petitioned or who have been contacted by their constituents who tell them that COPD is of importance to them. Would they please join the caucus? The benefit of having this caucus is you have a group of individuals who have already self-identified as having concern about pulmonary disease. So when we have legislation, when we have letters that we want drafted, when we have dear colleague letters, when we are accessing all of the tricks that we use to try to move and bend and change the federal system, these individuals have already told us as caucus members that they're willing to get engaged. Oh, this needs to change. We did identify a Democratic co-chair. It is Senator Dick Durbin. So the caucus leadership is comprised of Senator Mike Crapo. He's a Republican from Idaho, and he founded the caucus. He cannot get away from pulmonary disease. There is no way Senator Mike Crapo can escape us. Both of his brothers are very prominent pulmonologists, and his wife is a respiratory therapist. He's not getting off the hook. His co-chair in the Senate, Senator Durbin, who is the Democrat from Illinois, consented to join the caucus and to become the co-chair, partly at the behest of the Chicago Respiratory Group that asked him to get engaged. Unfortunately, we did have a woman who was our co-chair, and we need to have more women involved in leadership. And you've got a few women from the California delegation that have joined the Congressional Caucus. But it'd be really terrific if we could up that membership. So, on the state issues, we've got state coalitions and action plans. You're well aware of that. They focus on awareness. They direct the health department to include COPD in chronic disease initiatives, promoting early diagnosis. And one of the things that we've been rolling out that a number of insurance companies have focused on for some time, and wellness programs have focused on for some time, and that is a state, an employer's toolkit. And that allows individuals to go into their employment group and start screening for COPD and talking about disease management. We would ask you to partner with managed care health plans to demand quality care and access to education, and ultimately to pass COPD legislation in the state. And Dr. Richmond told me that some of that is going on right now, that you're taking a look at the Florida legislation and the screening issues that using Florida as a model. So, getting a state proclamation or a resolution is something that allows you to have an opportunity to promote COPD awareness. So it's not, I urge you in all the efforts that you do to not just take the step and achieve the goal, but also to follow up. And that's one of the ways that, that you could do that is the state proclamations and resolutions, when those come down from the governor, or do you get them through the, do you do a governor's proclamation in California? So when that comes down from the governor, some of them come through the legislature, not through the governor. So when they come down through the governor, that allows you to have an opportunity to have a press conference, to get some earned media, to get some coverage, to make a big deal about this. COPD Capital Awareness Days have taken place on the states. We've brought the COPD shuttle, which is Journey to the Center of the Lung. Who's been through the COPD shuttle? Only a few people in the room. What happens is, only John Walsh, our president and CEO of the COPD Foundation, could be so brilliant as to take an education video and turn it into a flight simulator so that people actually go and sit through an educational video. You get inhaled through tobacco smoke into the lung, and you journey through the lung, learn about COPD and its risk factors and its treatment, and then at the end you're spit out in sputum. So we bring our COPD shuttle on site. We include education materials. We do spirometry screenings. We have patient visits with the elected officials, key committee briefings, and then media outreach. And those have been very successful. The COPD Prevention and Education Act is a piece of model legislation that we're promoting. It has gone through the state of Florida. It has not passed in the state of Florida, but it's model legislation that was developed in Florida. And we've shared that here in California with you, and I know that, that Breathe LA will be making plans to carry that forward. I just want to note that one of the things that it asks for is a, I don't know how to go back. One of the things that it asks for is a needs assessment and an annual summit, which is a really great way to continue to keep alive what's happening with COPD and keep people energized about what's going on. The ideas for outreach that I would encourage you to get involved with include our pulmonary education program. And this is a program of the COPD Foundation. There is a sheet of information about what's available in that program. But basically what it is it allows you as an individual, when you go through pulmonary rehab, to go in and bring a package of materials and resources to the people who are conducting that pulmonary rehab, and let them know how they can help individuals and how they can help support groups form and get involved with the COPD Foundation and also local resources. And we'd be very happy to partner with you on that program as well, because this is a way for the grassroots to get the message out and get outreach to some of those people who may not actually have resources. They may have been referred directly to pulmonary rehab by their physician, and now they can come and connect back into advocacy and learn more about managing their disease. The BRFSS you heard a little bit about. The BRFSS is interesting in the fact that it is the data collection tool that allows us to understand what's happening on a local level, county by county, ultimately in the state, but also throughout the United States. And it's data that's very, very rich. So we now are asking a surveillance question about COPD on a national basis. That began in 2011, that COPD was added as a core question, which means every single BRFSS throughout the country that's running the BRFSS will be collecting this data. There was a supplemental module that was also paid for by in a strange twist of fate, by the National Institutes of Health. They granted money to the CDC so that the states could access adding this supplemental module. And we know that 20-some states added the supplemental module. So let me just tell you what that means. What that means is we're going to ask a question about COPD. And in 20-some states, including California, we're going to have data about what the utilization looks like. So if I'm the governor of a state where the BRFSS data comes in and it says, I have a high prevalence of COPD in my state, but I don't know anything about the utilization, how much it costs me to treat these people with COPD, I'm going to be angry about that. And it's going to be states like California that are going to come forward and they're going to say, we know what the prevalence is, and we also know what the healthcare utilization looks like. So this is going to be a groundswell that's really going to change the profile of understanding COPD. The other thing is, the reason that we know that people are obese in Mississippi is because of the BRFSS. This is the data that's been collected that lets us understand all of these public health concerns. So when you hear them packaged up and sent back out to us through the media, it all comes from the BRFSS, which means that data that's also collected as core questions in the BRFSS can be overlaid with COPD. So we'll know about COPD and comorbidities as well. And so this is going to enhance our understanding. So again, amazing that it goes from the community level to the state level to a national level and then is layered richly over other data that's been collected. So we're going to be able to really tell the story of COPD if we use this moment in time properly and get the data out there. And congratulations to California for being one of the states that applied for the supplemental module. We have a research registry at the COPD Foundation. The intention of our registry is really to allow individuals to participate in clinical trials. And we just saw a report, well, we participated as the COPD Foundation in a report that was released last week by Pharma. And you can find it on Pharma's website. They actually announced that 54 new drugs are in development for COPD. Those are in the pipeline and moving forward. I hope they are. I hope they are successful, and I hope they change the profile of treatment. So let me tell you about a couple of things that we've done on the federal level. So one of the things that we've done is we came together and we said that there's enough data, although it's proprietary data and it's held by the pharmaceutical companies, there's enough data that if we shared preclinical data, if we got all those pharmas to share the preclinical data, we could qualify what are called biomarkers. And the FDA has said that they want to change the profile, the way that they do drug development. They would like to be able to use biomarkers and expedite drug development. And so we worked with the FDA. The COPD Foundation's Biomarkers Consortium Qualification Group is really we are the poster child. So we are the ones who have come in and qualified the first biomarkers under FDA's change in their scientific approach to drug development. And we now have 3 biomarkers that are qualified. So drugs, what that means to you is that drugs in development for COPD will now be expedited because those biomarkers are available to everybody. Let me just see if I missed anything on my notes here. I think the one other thing that I wanted to say to you is that tobacco cessation is very important. And tobacco cessation can significantly reduce your risk for developing lung cancer. However, tobacco cessation doesn't necessarily reduce your risk for developing COPD. This is a disease that people are going to age into, and so taking a look at what's happening with individuals who are living with this disease and providing services to them, treatment, research, etc., continues to be critical.